There you go. Click your buttons and accept if you're willing to have this recorded. Thank you. So we come together because we want to have important conversations that, one, inform, often educate, make us aware, and give us the confidence that we need to be empowered to make decisions about our health for ourselves, our families, and friends. Today, I am thrilled to come back to you and say, while I was away, that I know every single one of you looked up Everyday Health when you had a question. I know you did. I know that you pulled that up because that's our trusted source and resource. For today's conversation, we have a topic that many of us don't often think about. We think sometimes about cirrhosis of the liver. We think about maybe hearing somebody might have a liver transplant. We hear about hepatitis C, B, but we don't really talk about in this forum liver disease. And I thought it would be a significantly important time for us to talk about the largest organ in the body and what it does, and why that is important for us to understand. We reached out, JAPS did, to the Liver Foundation. And the Liver Foundation was generous enough to give us Dr. Burke. Dr. Burke is a board-certified, trained general internist, but her specialty, we've got a hepatologist on board, y'all. We've got someone who specializes in liver transplants, understands liver disease, is going to bring to us a greater understanding of what we should know about health equity, of liver disease, and what it's all about. There's so many things that we can talk about. This won't be the last time that we have this discussion, but it's our introduction. So, Dr. Burke, I know that you're at the University of Texas Southwestern Medical Center. Is that correct? Okay. And I want to say to her, she's our family. She was trained over at Marshall University in West Virginia, so that's close. She completed her internal medicine residence. She's a WHO at University of Virginia. So she's our true family over here. And she completed her gastroenterology fellowship at Indiana University and a fellowship in transplant at the Cleveland Clinic. Now, she comes well qualified to have this discussion, and we're very thankful and appreciative to what you're going to share with us. So without any further ado, IT has delayed us and Lisa's talking. Here you go. Thank you, Dr. Burke. Take it away. Are you able to share your screen? And we can't hear you. Are you double muted? Let me see. I gave multiple. See if you can share now. I gave you that right. If not, I'll make you the host.
Okay, can you hear me now?
We can hear you, yes.
Okay, cool. My webcam, for some reason, it disconnected. So now I'm on the webcam on my laptop. So if I'm not making eye contact with you as I'm looking on my slides, I'm really sorry. And I want to make eye contact with you, but I don't know how. Okay. So what are you guys seeing? Are you guys seeing slides or hold on?
You were on your slides, so you were able to share just then, so that was perfect.
Okay, cool. There we go. Good.
Yes, perfect.
All right, wonderful. Okay, guys. Well, as Lisa so nicely said, my name is Indy. I am a transplant hepatologist at the University of Texas Southwestern in Dallas. I am originally from Nashville, Tennessee, and have kind of moved all over the place to do my medicine training. But I'm very happy to, have had the opportunity to train in a lot of different places. I think it makes me have a little bit of an awareness of what opportunities are available, what patients experience in a lot of different types of environments. And so I'm really happy to be able to kind of have this conversation with you guys today. I thought before we talked a little bit about, some kind of health equity issues in liver disease that, affect the Black and African American population, I thought it would be nice to just do a brief introduction to liver disease, because there's a lot of information out there and it can be really hard to know what's true and what's not true. And so we'll start with that. So this is a liver, and he's so happy that you guys are here, right? Okay, so whenever I see patients in the clinic and when I'm telling them things about their liver, what I really want them to know is that it's really important to take the things that I'm saying seriously, because liver disease is a big deal. And so this is the same thing when I have like medical students rotate with me, or when I have residents rotate with me. I want to frame a picture for why the things that I'm teaching them matters, or why the problems that I'm taking care of them matter. And so I want to put this into sort of like terms and a perspective that everyone can really understand. Chronic liver disease is a really big deal, and so we should really care about it. So just from a number standpoint, because everybody can kind of understand numbers, the absolute number of chronic liver disease cases in the world is estimated to be 1.5 billion. So 1.5 billion people in the world right now have chronic liver disease. It is responsible for approximately 2 million deaths worldwide per year. A third of liver-related deaths occur in females. If you're thinking about all the causes of death in the world, it's the 11th leading cause of death worldwide. In the United States, it's the 15th leading cause of disability-associated life years. So this means people who are, losing opportunities to work. This is the 15th leading cause for that. And then in 2016, so now this data is 7 years old, the cost of liver disease in the United States to the healthcare system was about $32.5 billion. And so if you can imagine now, 7 years later, that number is a lot higher. And so chronic liver disease affects a lot of patients. It unfortunately is responsible for killing a lot of patients. And it also costs a lot of money. And we probably would be much better served if we had a more proactive response to liver disease than a reactive response. And so that's kind of what I want us to think about as we talk through this next hour or however long we're together. So with those things in mind, the liver is a really big deal for patients. Okay, we talked about why it's important. These are some of the things that I kind of wanted to touch on. I want us to review the structure and the function of the liver so everyone knows where it is, what it does. I want us to describe the evolution of chronic liver disease so we all know what to expect. I want us to outline the basic complications of liver disease, some initial management strategies. So if you guys, have liver disease or are talking to people with liver disease, or interfacing with organizations that take care of patients with liver disease, then you'll sort of know what they're talking about. And then I also want to discuss some opportunities for improvement in the care that we provide. And this is really a discussion. I want to hear what you guys have to say about this as well. So in a lot of ways, I said I wanted to tell you why the liver is important. My other goal, which I'm going to be very honest with you, is to tell you on why the liver is the coolest organ in the body. And it's because it does all of these things. In so many ways, I think it's very underrated. People tend to know that the liver's basic function is like, it's a detoxifying organ. So people kind of think like, oh, it metabolizes alcohol, but they don't really know the extent to which the liver is essential for our bodies to run smoothly. So there are a lot of medical words on this slide, but I'm going to walk you through kind of all of the functions of the liver and why it's so important. And we're going to go across the top first. So the liver is responsible for the formation and secretion of bile. So bile is what allows your body to appropriately digest food. If the liver is not functioning well and it's not forming and secreting bile, then your body is not going to be able to digest and absorb the nutrients that it needs when you take in the food that you eat. The liver is also responsible for storing glycogen. Glycogen is a very kind of fancy word for your sugar energy stores. And so when you are, an hour or two past eating and your body has used up the direct energy that it gets from the food that you've just taken in, the liver is where the body stores the remainder of the energy that you have. And so that's really important. If your liver is not functioning, you're going to have really bad fatigue because your glycogen stores are going to be extremely low. body or the liver is also responsible for urea synthesis. So not only is it responsible for storing energy, it's also responsible for producing energy. So this is something that's really important. The liver is responsible for metabolizing fat. And so if your liver is not functioning very well, when you are eating, your body is not going to be able to metabolize the fat that you bring in, and that's not a good thing. It is responsible for creating proteins, and it's responsible for creating all of your clotting factors. So if you get a scrape or a cut, you're in the kitchen and I don't know, I was cutting an onion yesterday and I actually cut my finger. If my liver wasn't functioning very well, that bleeding would not stop. And so your liver is what makes your clotting factors. Your liver is a detoxifying organ like we were talking about. So when you're taking your medicines every day, whatever they may be, 95% of medications are metabolized by the liver. And so if your liver is not working, your medicines are less likely to be effective. The liver is also responsible for cleansing bacteria from the food you eat. So that's important. It's responsible for processing a lot of your hormones. So your steroid hormones, kind of your like stress response is responsible in part by your liver, and then also your vitamin D. Your liver is also a really good reservoir for blood. And so in a lot of ways, as your blood pumps throughout your body because your heart is kind of spreading it everywhere, a good portion of that is going to be hanging out in your liver. And then it's also responsible for the breakdown of red blood cells that are really very tired. So your liver does all of this stuff. And so if you have chronic liver disease and these things aren't going very well, you might have, as you can imagine, big problems. And so even with all of those responsibilities, what makes the liver really cool is that it's extremely resilient to a point. And so the liver is located in the right upper portion of your belly. We call this in medicine the right upper quadrant. So if you hear that, oh, it's the right upper quadrant of your abdomen. In general, your liver won't cause you any kind of pain. And so this is something that I think is kind of interesting. I see a lot of patients in clinic who are referred to me from other doctors who have belly pain, and they're like, oh, I've been told it's my liver. And what's interesting about the liver is that it really doesn't have a lot of nerve endings. And so the likelihood that it really is your liver that's causing you pain is probably really low. Maybe you've got gallbladder problems that are causing you pain in that area. And so that's something that you should kind of keep in mind. Your liver is unlikely to cause you like true abdominal pain. Your liver receives the majority of its blood from something called the portal vein. And so this is something to kind of keep in mind. This will be important if you end up, with chronic liver disease or taking care of someone with chronic liver disease. So the blood supply to the liver is extremely important to know. And then when people get scarring of the liver, or when patients, have cirrhosis, which is end stage scarring of the liver, it's really important to know that scarring can be reversed. And so we want to be really proactive about managing those patients. We want to make sure that they know this is not the end of the road for you. We still can do things to help you. And so that's something that's really important to know as well. So my first summary statement for you guys about the liver is this. The liver is in the right upper part of the belly. Its main jobs are to filter the blood of toxins, to metabolize drugs, and make proteins and clotting factors. So it does a lot of really cool things. Okay. So patients in general, when they are diagnosed with chronic liver injury, occurs when they've had like abnormal liver blood tests for a period of 6 months or longer. So when you are referred to a liver doctor like myself, and your primary care doctor says you need to go see a hepatologist, they're probably making that determination because your liver labs are high. And your liver labs are what I've listed at the bottom: your AST, your ALT, your bilirubin, a lab called the alkaline phosphatase, which most doctors will call ALK-PHOS for short, or the GGT. And so that's probably what causes your primary care doctor to say, hey, you probably need to see a liver doctor. So when someone has this kind of—
Can I stop 1 second?
Yes.
Emphasize, when you get your lab results back and you want to know what they're talking about, and it's about the liver, she's telling us to pay attention to AST, ALT, bilirubin, and the alkaline phosphatase and GGT. Note to self, these are your liver enzymes to pay attention to. Sorry, Dr. Indy.
No, that's perfect. I'm very glad that you interrupted me. And I hope you guys will interrupt and ask questions like as we go. Okay. I hear myself talk all the time. I have a 2-year-old. I'm always yelling. So you guys interrupt. It'll be nice. So I don't have to hear my own voice. Okay. So these are your liver labs. Okay. So if you're referred to a hepatologist, you probably have some abnormality with these liver labs. And when you see me, the conversation that I usually have with patients is, what now? So like, what does this mean? Do I have cirrhosis? Do I not have cirrhosis? Are my liver tests just high? Why is that? And what I want you guys to know is this. It really doesn't matter what the cause of your chronic liver disease is. It all looks the same, okay? Every type of liver disease progresses along the stages that you see on this slide, okay? Every type of liver disease, when it becomes end stage, ends in cirrhosis. So it doesn't matter if it's alcohol-related liver disease. It doesn't matter if you have autoimmune-related liver disease. It doesn't matter if you have hepatitis B or hepatitis C, or if you have non-alcohol-related fatty liver disease. It all looks the same. And so it's not one of those things where typically people think, oh, my liver is not, functioning. It's because of alcohol. That's really not the case. There are a lot of different things that can cause your liver to be angry, but regardless of what that thing is, it's going to progress along these same stages. Okay. The other thing that I want you guys to know from this is that cirrhosis really is the end stage of scarring of the liver. So what happens when you have liver disease is the following. First, you have something that irritates the liver. Okay, let's say, let's say I have metabolic risk factors. That means I have obesity and I have high blood pressure and I have diabetes. Having those things sometimes can make your liver a little bit angry. And so I have those problems and now my liver is getting a little bit upset. That can cause fat infiltration in the liver. So now I have fatty liver. The longer that I have fat in the liver, the more likely it is that I'm going to develop inflammation in my liver. So the longer that insult is there causing problems, the more likely it is to cause then inflammation. And when you have inflammation in the liver thinks to itself, man, I've got to do something about this inflammation. It's really bothering me. And so its protective mechanism is to create scars over that area of inflammation so that it doesn't have inflammation anymore. And unfortunately, what happens is that the more inflammation you have, the more scarring that you get, the more likely that it is you develop cirrhosis, because eventually if your whole liver becomes scarred, that's when you get cirrhosis. And in the olden days, we used to think that once patients had cirrhosis, then that was it. They were going to have cirrhosis for the rest of their life and there was nothing we could do. But I put this arrow on the bottom of this picture under the stages of liver disease, because what I want you to know is this. Liver disease is reversible if you take away the insult that's causing the problem. And so if you have cirrhosis, this is not necessarily like a life sentence for a patient. If someone has alcohol-related cirrhosis, but they stop drinking, their liver can get a lot better. Their cirrhosis can get a lot better. In fact, that scarring can go away. And so these are things that we really need to be aware of and kind of understand. This is something that we should be actively managing and proactive about instead of reacting to. Do we have any questions on this? Because this is an important point.
So if the reversal of it, what's the time frame? So what can we expect? If I stop drinking for 6 months, what percentage of scarring goes away?
Yeah, so 6 months is actually, from an alcohol standpoint, a really good kind of indicator of how much improvement you're going to get. So we typically say like 6 to 12 months is the time frame in which you're going to see a lot of improvement. And so you may see that the percentage of scarring goes down 1 to 2 stages. So if you're in the cirrhosis stage, maybe you bump back to hepatic fibrosis or some fatty liver. If you're in the hepatic fibrosis stage, maybe you bump back to the fatty liver stage. And so you usually can walk yourself back 1 step. And if you're really lucky, maybe 2 steps. And so that's a big difference though, because we don't really have problems with chronic liver disease until you have cirrhosis that's really far along. And so if you can catch it early, or if you're really aggressive about sobriety, or you're really aggressive about weight loss, if you have non-alcohol, related liver disease, then those things can really, do a lot to sort of help the liver, improve.
This is Mary. So if you actually have blood tests done on a routine basis, like maybe every year, you can stay ahead of something like this?
Yes. If you have blood tests done every year, what you'll be able to see is abnormalities, specifically in the AST and the ALT. Those are usually the earliest predictors of some type of liver damage. And so that's a really good kind of initial screening test for a liver problem. And so if you're sort of seeing persistent, even if you're seeing persistent low-level elevations in your AST and ALT, that's cause for you to go back to your primary care doctor and say, hey, you haven't mentioned this to me. Even if they're, just 10 above the upper limit of normal, that's something that you need to talk to them about, because that's probably an indicator of underlying fatty liver disease. Any other about that?
Is that test routinely done when you have your blood work? I mean, I get a whole list of things. Is it there and I just haven't zeroed in on it? Oh,
yes, it is routinely done when you have your blood work.
I'll go back and look at it.
Yes, it will be there. Okay. When someone progresses to cirrhosis, we really think of it in one of two buckets, okay? We start to see problems, like I was saying, when patients have cirrhosis that's really far along. And so we call those patients decompensated cirrhosis patients. And so I want to just sort of put in your mind the difference between somebody who has compensated cirrhosis and someone who has decompensated cirrhosis, because for two reasons. One, I want to, again, kind of impress upon you the importance of being able to walk this back, because it really means a lot. It's a lot different for a patient if you can walk back decompensated cirrhosis to compensated cirrhosis, or if you can prevent someone from becoming decompensated. So when patients have decompensated cirrhosis, their average life expectancy is 18 months. Decompensated cirrhosis means that the liver cannot carry out its normal function. And these patients usually have complications of liver disease or complications of what we call portal hypertension. So if you remember, I said that the primary blood supply to the liver was the portal vein. And so patients who have decompensated cirrhosis have problems because the blood pressure in their blood supply to the liver gets extremely high. And the reason for this is because the liver is so scarred now that blood cannot flow through it the way that it used to. And it's really simple plumbing, okay? If you think about a hose in your garden, if you put a kink in that hose, you get a lot of back pressure, and that back pressure causes problems, okay? So the same thing happens in the liver. If you have really bad scarring in the liver, then that blood supply gets a really high back pressure, and that back pressure causes a lot of problems for the rest of your body. And so what we want to do is to prevent people from getting portal hypertension or high blood pressure in the portal vein, okay? Contrast this to somebody who has compensated cirrhosis. So that means they have cirrhosis, but they don't have problems with portal hypertension. So these patients have an average life expectancy of 12 years at least. They have a lot of times no idea that they even have chronic liver disease, and their liver is working fine. What's really important to know is that cirrhosis usually develops over a period of many, many years. So you will have some indicator in your blood work or on routine imaging or on some routine test that has been done that you are developing liver disease at some point. So typically cirrhosis has a lot of red flags that it's developing before it actually is developed. And so we estimate that about 90% of liver disease is actually preventable if people are paying attention to their labs. Questions about that? My second summary statement is this: cirrhosis is the common end pathway for all causes of liver disease. Complications of cirrhosis occur in the setting of portal hypertension, and that's that high blood pressure in the portal vein. Okay.
Okay.
So one of the questions that I get from
So
patients,
the high blood pressure in the portal vein, is that different than just regular high blood pressure?
yes, it is.
Okay.
It is different than regular high blood pressure. So this is not the same as like, having, just run-of-the-mill hypertension. Portal hypertension occurs only in the setting of specific abnormalities in the liver. So one of the biggest questions that I get from my patients is, how will I know if my liver is getting worse? So like, let's say somebody that someone that you care about is diagnosed with cirrhosis. One of the questions I hear all the time is like, well, how do I know if my cirrhosis is getting worse? And the unfortunate case is really this. While your labs may indicate that you're developing cirrhosis, once you develop cirrhosis, there's not a lot of indicators that your cirrhosis is getting worse. And so really, we need to just sort of be very proactive about monitoring patients for symptoms. And it's the symptoms of that back pressure that cause problems. And that's what we really want to prevent patients from getting. So the three things that are the most kind of worrisome complications of cirrhosis and portal hypertension, I put in these red boxes for you. One is ascites, one is hepatic encephalopathy, and one is called varices. And I'm going to talk to you about each of these, okay? So the first one, ascites, is basically fluid that accumulates in the belly. Patients who have ascites look like they're pregnant, even though they're not. They have the pregnant belly, they're very swollen, their bellies are extremely distended. These patients often will tell you that they've been gaining weight for months, gaining weight for weeks. They usually have really bad lower extremity swelling too, so their ankles are going to be really swollen. Oftentimes, they're going to be really short of breath because their bellies are so distended now, they can't get a full breath anymore. And the fluid accumulates because as the blood pressure increases and the liver is scarred, that blood doesn't have anywhere to go. And so it just backs up and it leaks into the belly and it sits there and it accumulates. And so this is really just the body's kind of response to a mechanical obstruction of flow. Okay, so that's called ascites. Ascites fluid has a very high risk of getting infected, and that's called spontaneous bacterial peritonitis, which you also see boxed. This infection can be life-threatening. And so we work very hard to treat ascites when it occurs. That means we work very hard when patients develop this problem to keep the fluid off, whether we give them water pills like diuretics, Lasix, those types of medicines, whether we put a needle in the belly and just drain the fluid. We do everything we can to keep that fluid from accumulating, because if it's there, the risk of infection is high. So that's the first thing. The second complication that we worry about is something called hepatic encephalopathy. So if you guys remember, I said that the liver does a really good job of kind of ridding the body of toxins, right? So this is a really good waste management system. Hepatic encephalopathy occurs when the liver is unable to rid the body of toxins, and those toxins build up in the bloodstream. They go to the brain where they accumulate, and then they cause confusion. And so this can be a sign of progressive liver disease. It can occur in patients who have cirrhosis and have like a concurrent infection. So sometimes the only way that you'll know someone has an infection is because they're coming in and they're really confused. What ends up happening here is that because the liver is not seeing blood flow because it's so stiff and it's not getting exposed to all the blood that it needs to do its job as a good filter, the toxins are just accumulating. And so that's how people get confused when they have liver disease. So that's another thing we worry about. And then the last thing that we worry about is something called varices. And varices are abnormal blood vessels that grow as a result of this high blood pressure. And so the body thinks to itself, can I do anything to overcome this pressure? Is there a way that I can offload the pressure on my liver to make it easier on myself. So if you think about that hose analogy, if you put a kink in your hose or you have pressure in your hose, if you add an additional spigot, right, the amount of water that comes out is like much slower. Okay, so the body creates these varices, which is essentially like an additional blood vessel to offload the pressure. It's like an additional spigot. But what ends up happening is as the pressure continues to get higher, there's a risk of bleeding in those new blood vessels. And those bleeding blood vessels can also be life-threatening. So people can come into the hospital throwing up blood or bleeding from their bottoms, a lot of blood. And so that's a concern that we have in patients who have liver disease. And so, as I was saying, the whole name of the game in liver disease is being proactive. Proactive, preventing things. So how do we manage chronic liver disease? How do we treat these patients? And the first thing is to reduce portal hypertension, right? We want to reduce the blood pressure in the portal vein. And the way that we do that is by medications. So the mainstay of treatment for portal hypertension are non-selective beta blockers. These are medicines that you probably know about, like Coreg or carvedilol, because you also take them sometimes for your heart. And so these are blood pressure medicines that initially we know work for the heart. And now that we've had them around for a number of years and we've been able to study them in liver patients, we know they're also really effective at lowering the blood pressure in the portal vein. So this is what we give patients. The other medicine that we use to reduce the blood pressure in the portal vein are statins. So these are the medicines that you're prescribed for cholesterol problems, like atorvastatin or simvastatin. Those medicines also reduce the portal pressure. And so we use these medicines in combination. Having cirrhosis also increases your risk, unfortunately, of developing liver cancer. Liver cancers, though, are extremely treatable if we catch them. And so similar to doing things like getting your colonoscopy for colon cancer screening or getting your mammogram for breast cancer screening, if you have cirrhosis, we recommend that you get an ultrasound of your liver every 6 months. Because if we see an evolving liver cancer, that is very easy for us to treat when we find it early. And so we can just cut it out, we can zap it out, and people, just go on living no problem. And so we recommend every 6 months that they get an ultrasound. And then the other thing that we recommend for our patients is that they stay up to date on all of their routine healthcare maintenance, needs. So this is age-appropriate cancer screening. So like I was saying, colon cancer screening, breast cancer screening, cervical cancer screening for women. But also we want to make sure that those patients who have cirrhosis are also immune to hepatitis A and hepatitis B. So these are vaccines that people typically get when they're younger, but it's very common to lose your immunity, especially to hepatitis B as you age. And so we always want to make sure that people retain their immunity to hepatitis B and hepatitis A. And if for any reason they have lost their immunity, we want to boost them in the clinic. Because if you can imagine, if you already have cirrhosis and then you get this really bad virus that, directly affects your liver, you're going to make your liver a lot worse. And so this is something that's really easy for us to do that has potential huge payoff. And then liver transplant is an option for patients with decompensated disease who are otherwise failing treatment. And so liver transplant is offered to patients when medicines to reduce their portal hypertension are not working, when they've got a liver cancer that we're unable to treat, or when they have other problems that we're just not able to keep up with. That confusion that they're experiencing, hepatic encephalopathy, is so bad, medicines are not working anymore. That's what we consider transplant. So my next summary statement is this: patients with chronic liver disease should be seen by a specialist every 6 months. So if you have chronic liver disease, I want to see you in my office at least twice a year. And I want to be proactive about managing you because I would much rather prevent a problem than have to treat one. Any questions?
Yes, I have a question. And on your slide that showed the decompensated box,
Yes.
you spoke to 18 months to live.
Yes.
Based on the treatment recommendations that you just provided, associated with treating those symptoms for portal hypertension,
Mhm.
does that extend your chances of living beyond the 18 months? And was that 18 months just to figure without any type of treatment?
So this is with treatment for portal hypertension if you have decompensated disease.
Even taking those medications. Wow.
And so if, if you have decompensated disease, the minute that you decompensate, and decompensation is defined as developing ascites, developing hepatic encephalopathy, developing bleeding varices, or developing a liver cancer, the minute that you develop one of those 4 things, I'm automatically thinking about whether or not you're a candidate for a liver transplant, because that's my best option to extend this life expectancy. And so that's really where, our opportunities for treatment when people have decompensated disease really come into play.
Wow. Woo.
Yeah, it's like ice water, isn't it?
Mm-hmm. But that's good to know that you can now watch your your labs and do some things about it if you haven't been watching them, and your primary care physician is not calling them out. They're looking more for cholesterol or blah 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 blah. So
Yes.
yeah, thank
We
you.
see that a lot. So that's a really good point. I mean, I see in clinic every day, oh, my primary care told me it was just fatty liver. Just fatty liver is not a thing. Fatty liver is a problem. And so I hate when I hear that, because I'm like, oh, now
Yeah.
we have a big problem. And maybe it was just fatty liver 10 years ago, but now it's, decompensated cirrhosis. And so like, that's why I really want people to know, like, it's reversible if you catch it. I mean, it's reversible at all stages, but it's preventable if you catch it early.
Yeah, NASH is what NASH is getting a whole lot of attention now for this reason, I think, right?
Yes, that is NASH, non-alcoholic steatohepatitis. Mhm.
Right. Okay, great.
And so I guess, speaking to you guys, what I want you to know is that you should be really empowered to speak up for your health. And there are a lot of disparities that exist, in all facets of care for Black and African American populations. But in cirrhosis care specifically, the gap is really, really big. And so I don't want you to get like bogged down in, what these tables show and like what these graphs show. I'm gonna tell you what they show, but I just want, to kind of show you that there is data for what I'm gonna say. So to prevent cirrhosis, like we were saying, the first step is being aware of your disease. And so a study from 2014, which was a really good study, showed that 69% of patients with cirrhosis were unaware of their diagnosis. And compared to the general population, there were much higher rates of unawareness among Black patients than white patients and Hispanic patients. There were also much higher rates of unawareness in patients who were living below poverty line. And advanced disease at initial presentation was much more likely to occur in Black patients than it was in white or Hispanic patients. And so this is a really big problem, because it means that we're not doing enough to educate, 1, 2, build inroads in communities, but 3, also to provide access to care. And so we really need to think about ways that we can be good at all of those things. One thing that I had a lot of hope for was whether or not telehealth was going to be a means to kind of address some of this disparity. And unfortunately, what we've seen so far from a cirrhosis standpoint is that that's not really the case. And so there was a couple of studies that have come out recently, kind of born of like the COVID pandemic, that looked at patients who have cirrhosis that we are trying to see in video visits. And one thing that we're seeing is that Black patients who are seen in telephone or video visits have much higher rates of incomplete or failed video visits than white patients. And if they're Black patients who are on Medicaid, then the rate is even higher. And so that's also a really big problem. And then there was another study very recently that was published of over 1,500 video visits that also looked at, my chart utilization between patients. So I'm using my chart, right, to send notes to all of my patients. Like, oh, we've got your labs. I'm gonna tell you what your labs are in my chart. But what is so interesting from this study, which was like so impressive to me, was that In this study, the portal was used by 87% of white patients compared to just 39% of Black patients. And so that was really impressive to me. And I feel like, you know, I'm maybe not capturing my patients when I'm sending them notes in my chart. I had no idea that this disparity even existed. And the other thing that's really important, and I've seen this having worked in, you know, Metroplex areas in, you know, safety net hospitals, is that in a large study of hospitals, minority hospitals who treat patients with chronic liver disease and cirrhosis have much higher proportions of mortality than non-minority hospitals. And so the reasons for this are many, but one of them goes back to what we were just talking about, which is a lot of patients are unaware of their disease. And so when they're presenting with cirrhosis, they're presenting with cirrhosis that's decompensated. They're never being seen in that compensated phase. So we never have an opportunity to help underrepresented patients early on. And we're seeing them when they're already in the hospital and they're already really sick. And at that point, it's usually, you know, too difficult to do something. And so mortality from chronic liver disease and cirrhosis in Black neighborhood hospitals and safety net hospitals is much higher than in other hospitals. And so that's also really important to know. And then the last thing is that this is also not just liver related mortality, but it's also all cause mortality, meaning it doesn't matter if you're dying with, you know, cirrhosis related problems, but if you have cirrhosis, if you're a Black patient in a hospital, you're more likely to die regardless of what type of hospital you're in, minority or not, and you're more likely to die from any cause, whether that's heart disease, kidney problems, some type of cancer. And usually this is due to problems with access to care. And awareness of contributors to disparity is essential. And I know you guys know this, but I think this is something from, you know, a healthcare standpoint as a provider that we're starting to be much more aggressive about talking about with our patients. And so when I'm seeing patients in the clinic, I'm specifically asking them, like, do you have access to food? Like, do you have stable incomes? You know, where do you live? Like, what kind of neighborhood do you live in? Are you safe? You know, are you next to a park? Are you next to a supermarket? Are you instead going to McDonald's? Who's in your household? Like, who's your support? Do you have a church community? Who can bring you to your, you know, who can bring you to your visits? Who's not? And the problem is because there are a lot of modifiable risk factors in the middle of this graph that we could do a lot to help our patients with to maybe mitigate some of those disparities that I was just talking to you about. And the reality is we've done a lot to maybe focus traditionally on the bottom part. Like, how do we improve getting patients to clinic visits? How do we improve hospitalization rates? How do we make sure, you know, less patients are dying? But if we're looking at downstream problems, we're only making changes I mean, honestly, we're making changes when it's too late, right? It's not going to do anything. And so I'm really trying to focus the attention of my patients and my practice on some of these more like midstream areas. And so I encourage you guys to also do the same for the people that you're taking care of. How can we sort of do what it is that we can in these specific areas? Are there programs that we can provide and those types of things? So I work predominantly, you know, as I said, at UT Southwestern, but I work at Parkland, which is the Dallas County Community Hospital. It's a safety net hospital. And this is something that we take really seriously. So our patients don't have insurance. That means when they're sick and they have liver disease, there's no way to get them a liver transplant because they can't pay. And so we're working really, really hard to, you know, figure out ways to implement programs to prevent them from ever getting to the point where they need a liver transplant, because we know we're never going to be able to provide it to them. And so these are things that I care about because my patients, my patients will never have that opportunity. And so the last thing is this. You guys know this. I know this. I see this in my patient population, but Black patients experience significant differences in access to care, in all access points to care, but especially in cirrhosis that result in poorer health outcomes, higher rates of death, higher rates of complication, worse rates of decompensation. And so this is something that we need to be aware of. And then I wanted to say thank you guys for having me. This is my email. So if you guys have questions about liver disease, you can email me. I live on my email, much to my husband's chagrin, but I will get back to you. And so I want to hear from you guys. If you have questions, I'm available. This is a pleasure to be able to do this for you guys. And also, it's important, I think, that people get their questions answered. And if you're not getting your questions answered from the people who are taking care of you, I'm happy to be that resource.
Oh, thank you so much. And thank you for your generosity of sharing your email so that we can ask questions. I have a burning question right now.
Yes.
After hearing seeing the disparities and
Yes.
seeing the cirrhosis and the compensated 12 years, what are those things you recommend that we are aware of other than lab results that can trigger us to better care for ourselves?
So the biggest thing is to mitigate risk factors that are going to worsen your liver disease. And so let's say you have alcohol-related liver disease and you've stopped drinking. That's wonderful. And I commend you for that. And stopping drinking is going to do a great thing for your liver. But if you have high blood pressure and you have diabetes and you have cholesterol problems, you're still not helping your liver. Right. And so it's being aware of kind of your global health and how multiple things can affect your liver simultaneously, and being able to mitigate all those risk factors in a way that can be kind of most helpful to your liver globally. So what I tell patients is this. My focus when I see people in the clinic is to help them live the most balanced life that they can. I recognize that there are things that happen that, sometimes you want to have cake, right? Sometimes you want to have a glass of champagne because your daughter's getting married or whatever. I firmly believe that you can do things right 80% of the time to enjoy your life 20% of the time. And if you do that, your liver should be just fine. However, if you reach a point where your liver is so sick that you are having those decompensation symptoms or you're at risk for decompensation symptoms, your doctor is going to tell you. And that is a wake-up call where you need to say, I've got to do something different. And the other thing that I tell patients is, if you're one of the patients who has non-alcohol related fatty liver disease, which is the majority of the patients in America now, right? Because obesity is a pandemic in America, or an epidemic actually. There is no shame in accepting medication weight loss or medication assistance for weight loss. And I am really aggressive with my patients about putting them on medicines. And the reason for this is because the studies that have shown the most improvement in reversing scarring in the liver for patients with non-alcohol related fatty liver disease have shown that losing 5 to 10% of your body weight is the most likely to get you there. And so I'm like, weight loss is hard. Like, whoever just says it's calories in and calories out is lying to you. Like, that's not how it works. And so take the help and just, medications are there to help you. And so I do that with my patients as well.
How much drinking would cause alcohol related liver disease?
A lot. Okay. You have to drink a lot. So first, there are a few genetic predispositions that can cause you to be more likely to develop alcohol related liver disease. But in general, you need to be drinking, 3, 4, 5 drinks at least a day for a period of 15, 20 years.
Oh, good. I'm good.
Or you need to be drinking a pint, 2 pints of hard liquor a day for a period of 5 or so years.
Okay. Don't have that to worry about.
I mean, I'm like a glass of wine a night drinker. I won't get liver disease with that. So, yeah.
Lisa, I just have a couple of comments. And one was the statement that you have access to care is not equal and knowledge of the disease is not either. That's why I want to give you so many accolades for bringing this to us, because many times you go to the doctor and they give you 20 minutes, 25 minutes max. But here, even though it's a small environment, we can ask questions. I can see pictures and like, wow, I didn't know the liver was cut like that. It looks like, you just don't have time. And thank you so much for doing this. Mind chart, I would give a lot of what I want to say, points on using Mind chart. Even when I'm in the hospital, I have my smartphone. When they pull that blood, 2 hours later, I'm looking to see what the results are. So when they come back, I will have my own questions because again, I feel that you have to be your own advocate. When the doctor comes in, he only has X number of minutes to spend with you. But if you have your questions all written down, I've even had cases where they said, may I have your list of questions to take with me? Or can I read them myself? Write it down, use my chart. I tell you, I talk to my doctor just like he's my best friend because I send him emails all the time. Maybe he gets tired of them, but he doesn't say it. Sometimes the nurse answers it. But at least it's a venue of communication that you might not ordinarily have. A phone call, you're not going to get an answer like you would to my chart. Thank you.
Excellent.
You love my chart, so I echo that. If you're using my chart, then I'm happy. It makes it a lot easier, to communicate.
And
So
you can Xerox things off of that to keep for your own record so you don't have to go to the computer all the time. Something that's interesting, they've told me, I said, oh, I need to make a copy of this so I can put it in my little easy folder. When I go to another doctor, I can say, look, these are my results for this, and these are comments. Thank you. I'm finished.
No, don't be finished. But I'm really intrigued by the fact that those numbers were low for using my chart and apps when most of our households don't have phones, but have smartphones that we could do that. Were there answers as to those discrepancies and differences shared around the telehealth and those differences that you can share so that we may be able to share with our community ways to overcome some of that?
Yeah, so, it's a really good question. And one of the biggest things that came out of some of those studies was the initial enrollment in my chart. And so if you guys remember when you first enrolled in my chart, probably what happened is you got a code from your doctor's office and you went on your email and you put in your my chart and you had to type in like a really long code. And what ends up happening is people lose the code. Or they, they're like, I'm going to do it later, or for whatever reason, they kind of walk out or don't get the code. And that was the biggest reason why people said that they weren't using my chart, was that they didn't know how to access it. And then when they did follow-up questions about why that was the case, white patients who lost their code reached out. Black patients who lost their code did not. And so this is a good point to what Mary was saying, which is you need to be your own advocate. So if you have lost your code or whatever, like, we are there to help you. And so this is the way, this is the time to reach out and say, hey, listen, I cannot access this. Can somebody help me? But that was the difference in the study.
Is there a social worker or a nurse navigator that would be at an office that at the end of an appointment with a new patient, they can enroll them right there with the code so that doesn't happen at your practice?
That's what I do.
Okay.
I just enroll them right there with me because it's easy in the clinic and it doesn't take me very long. But I think some people maybe haven't, integrated that into their workflow or really understand or are aware that this is an inequity that exists. And so they probably aren't really considering it. Or because they use my chart so frequently, like as a physician, we're kind of glued to my chart. I think we sort of feel like our patients are as well. But I think we forget that a lot of our patients actually don't, really understand how to use it or what it could be useful for.
My final question is this. You identified what I think of as metabolic syndrome for diabetes, but you identified it for the liver as well, as what I was hearing, those same things that are taking place. So I have homework to help with educating that it's these same risk factors that impact the liver that are causing the diabetes, that give us that metabolic syndrome, etc. So you have been a gift to us tonight. I thank you. On your behalf, the Liver Foundation, I want to thank them. I don't know who to write, who to thank, but this was just so tremendous what you've done. If you come back and go to BAAHRI.org, what you will find is this recording will be on our website and it's archived, and everybody who was invited to this call will get in case you missed it, and they'll get this recording and they get it. So we have a mailing of over 100 people. So therefore,
That's awesome.
these people will get it. And thank you very much for what you've shared tonight.
Yeah, no problem. The one thing that I want to say before you leave, just about your comment about metabolic associated liver disease, is the following. We've actually renamed non-alcoholic fatty liver disease and NASH to metabolic associated steatotic liver disease. So it
Okay.
is a new name now, although people don't know the new name. And so in clinical practice, it's like very hard for us to say it because people still think of it as non-alcohol fatty liver disease, but it is now metabolic associated. And so that should make your point.
I was on to something, huh? That's
You were.
good.
Mhm. Yeah, you were on
Okay,
something.
so you mentioned you have over 100 people getting this email. You
Mhm.
know, could this be why people are not using my chart? I mean, they're not even coming for information that
Mhm.
we're making available to them. So they're the same ones that's not using the my chart.
People prioritize, but what we've understood is if they want to come back and get it, we're going to make it available to them. We're not going to penalize because you don't come. What
Right.
we want to do is still make it available. And what you have is information to share with your tentacles with other people. So you can reach out and touch more people and share and bring others. Because I don't, it's just, Dr. Indy, these are friends who we would talk about health all the time. And we got tired of just talking about it. I said, let's bring others to the conversation and share the conversation. So this is how this came about, so that we
Awesome.
can be empowered. So
Yeah, I
we're
guess my question is, how can we get more people to take advantage of this? And I have the same thing going on. I have a husband upstairs who's not listening to it. So
Now, I have a husband, and I was going to say, even though you don't see him, he's listening because this is important. He didn't want to, he wanted to keep he didn't want to put on a shirt over top his other shirt. So I said, just listen.
Well,
But
at
it would
least
be
he's
nice. I know you
listening.
said you wanted to keep the group small, but I was just
Listening.
thinking, even if we got 5 more, and then they can go out and just share this information,
And
even
we
if they don't actually come, and it's out there. So I don't know.
If I may
varies.
interject, Lisa.
Yeah.
Hey, everybody, I try to sit in the background and stay out of it, but I'm so much in love with all the comments. And thank you, Doctor, for such a fantastic presentation, very informative, and obviously, as you can
Awesome.
tell, very helpful. But I would like to encourage you all, as Lisa is alluding, by all means, reach out to your sphere of influence, your network, and let people know about this. Now, as Lisa is also alluding, we found in other aspects of research that we're conducting that unfortunately people prioritize things when they don't fully understand the risk and the exposure they have. And that's okay. But here's the thing. If you're not going to attend this, then let's use the tool, because it's recorded. Let's use this tool to, even if you talk to people, come back to Lisa and say, hey, Lisa, there were several of my friends, or even a group, or even an employer, or a university, or sorority who did not attend the meeting, but we would like to ask them to go watch the video and then have a Q&A with Lisa and one of the medical team. So you can recycle this information, and that's why we record it. And it's very important so that we can continue to get the message out. The last thing I'm going to say before I run away, since I've butt my face in, I'm going to say a little bit more here. The comments the doctor was referencing with regard to the disparities, we all know that, right?
Mm-hmm.
We see it happening in our families, in our churches, and in our surroundings. But it's time to stop. That's the way it was. And as you can probably tell through social media and the movement that is happening globally, Black people and African Americans, I hate to use Black people, but whatever, African Americans are beginning to show some awareness and interest in those matters that involve our community across a broad array of areas. So now is the time to raise the flag and to have that conversation. You'll be more received than you would have been traditionally. So I encourage you all to continue to do that. Thank you. I'll shut up.
I just have one more comment, and then I'm really going to be finished. When we talk about the disparities, remember, early voting is on. Listen to what those people are telling you. There are people out there who can do something about this. So we need to let them know that that's what we needed. And even in the medical profession, there is a need for more cultural competence for them to be aware of what, I mean, a lot of times they're aware, but to ensure that they know what's going on and do something about it. Let them know that you know.
Well, Dr. Burke is doing that. It's evidenced by the way that she presented the information and the slide that you showed at the end as to where you want to begin things. I love the top of it with policy and things. So you're very aware. Thank you for taking the time again with us. And go home and love your 2-year-old and
yeah, she's home with dad. You know how that goes.
yeah. So thank you. And if we do a second one, would you be willing to come back to another group?
Absolutely. Reach out anytime.
Yeah,
Thank
I
you.
never knew
So-
the liver did so much. I always
It's cool,
thought
right?
of the liver as just cleansing the blood. I didn't know it did all those other things too.
Yeah.
Well, thank you, everyone. Next month, we'll do something. It's October. So, of course, we're going to do something with breast cancer, and we will have a patient come and share their story with us and their journey. And that'll be good. And it's from, who is it, Japs? Sisters Network is coming. Someone from Sisters Network. So, everybody's going to have on pink next month, Indy. So that's great.
That's good.
Thank you. Have a good evening. And sorry
Bye-bye.
for the technical difficulty. All right.
Thank
Okay.
you.
All
Good
right.
night.
Bye-bye.
Thank